Right, I think we will get started. We had about 60 people signed up today, but I'm guessing that people will be coming in as we are presenting. I've started recording. Yeah, that's working. Let's hope Hina is on her way. Great. Okay, lovely to see everybody. I was just looking with interest who's coming in. We've had a really great breadth of people signing up today. I think how to use these roles has been a kind of a topic that I feel like has come into a lot of the work that we've been doing. I'll introduce myself in a sec. I just wanted to let you know a little bit about the plan for today. So today's session is covering why personalised care, the personalised care roles in primary care are important, and how it relates to health inequalities, what the three roles are, and the benefits to a PCN and to primary care, and obviously the patients in using these three roles. We're going to look a little bit about how this relates to health inequalities, and have been talking to quite a few of you about some of the challenges you're facing, and I'm going to explain a bit about my role and Hina, who's going to be presenting with me today, about what the focus of our work is going to be for the next few months, and really we're looking to shape that support with yourselves going forward. So we'll have some time at the end just to have a bit of a discussion around what kind of ongoing support you guys think would be useful in embedding these roles. We had about 65, 70 people sign up. I'm obviously not expecting everybody to come in. But it is so I would say put yourselves on mute and use the chat. It's an informal session, so please feel free to share any observations or comments or questions. I'm going to be monitoring the chat once Hina arrives. So if you have got any really important questions, we're happy to take those as we go. There will be some time for questions later on, but obviously if you've got a burning question as we're going and it's relating to what we're presenting on, then pop it in the chat. This is quite, whilst these roles in some cases have been used in primary care for a very long time, we're all developing this as we go, and it's really important that the resources that we are pulling together in our work and the is co-produced, is coming from the people that are doing the work on the front line, and that this is very much, we're hoping going forward, going to be a platform for people that are doing things with these roles in the system. It may not always be a good story. It might be we tried and this is how we failed. But hopefully there'll be lots of opportunities to introduce people who are doing some really exciting things and have got a real vision for how these roles can transform the way that primary care is working and ultimately the patients that it's supporting. The session's recorded. There is some slides at the end with a bunch of resources that NHS England have suggested are useful, but we may also reference in our conversation. Any resources you have found really useful, or websites or reading that you've done that you've found useful, pop that in the chat as well. We will go through the chat and pull all of the things that people are referencing out and make sure that it's in the pack as a resource pack. At the end to share with everybody. These slides are also a work in progress. So if there's something that's missing from this presentation or something that you want to hear, please let us know. Again, the chat's a really good way of doing that. I'll drop us an email afterwards. Caroline, Hina's just texting to say that she doesn't have the Zoom link.
I've just sent it to her. But Billen's also on the Teams link as well. So I don't know whether some people are on the Teams link and not the Zoom meeting.
I tell you what I'll do when Hina's in, I will stop presenting and I will send out a great. So sort of the last thing I'll say is I've worked for, so to introduce myself, my name is Leanna Martin. I'm the Programme Manager for Social Prescribing at Healthy London Partnership. And I have worked over the years in various different settings, that in roles that have really connected with social prescribing in some way, and was probably doing social prescribing years ago without calling it social prescribing, but working with an individual to think about the things that we could shift that were going to have a meaningful impact on their health and well-being in their lives. I started my role as the regional learning coordinator for social prescribing at the Bromley by Bow Centre, and in the last few months I've moved over to Healthy London Partnership, and I'm looking at a programme of work that's thinking about how to develop social prescribing across London and really ensure that we've got the right conditions for it to thrive. My time is dedicated to supporting link workers, thinking about these initiatives that can develop social prescribing, and more recently have been working on supporting PCNs. That came about a number of people in the regional learning coordinator roles across the UK. We were supporting the workforce, supporting them in thinking about how to best embed themselves within primary care. And we fed back to NHS England, we can do as much work with the frontline workers, but actually the PCNs are stretched. They don't have the right support to ensure that these roles are being utilised in the correct way, and we need a two-pronged approach. And so NHS England made some resource available so that we could do some more focused support, offer some more focused support to primary care networks in utilising social prescribing, and then more recently the other two roles. We really felt that we needed, if we're engaging with primary care, we needed to have primary care embedded within our team. So we went out, and we're very lucky to find Dr. Hina Shahid. I'm going to let her introduce herself. She's lots of things. I came across her first when she was presenting to link workers on how to ensure that they were operating with culturally appropriate practice, and was really kind of inspired a lot of people in that presentation. So we're very lucky to have her on board. Hina, are you there?
I am. Thank you so much, Leanna. And apologies for joining slightly late. I couldn't find the Zoom link. I'm Hina Shahid. I'm a GP in Northwest London, working really closely with Leanna in the PCN advisor role. So my background is also in public health, where my research and practice has really focused on the social determinants of health, and really trying to work out ways of better supporting healthcare professionals to really embed this social model of healthcare, which we know is so important to health outcomes. I've done a lot of work with migrant, refugee and ethnic minority communities in the UK and abroad, and looked at developing culturally appropriate and sensitive healthcare services to them. And so I was asked to speak at the NHS England social prescribing webinar earlier this year, and sit on their national team, the National Steering Committee for Culturally Sensitive Social Prescribing. So it's a big passion of mine, and I'm really excited to be working with Leanna, with PCNs. We've got so many people that turned up today working across the healthcare system, so really looking forward to working with all of you. We also have Caroline here, who's the health and wellbeing coach mentor for London. And I wonder whether you'd just like to introduce yourself, Caroline, as well.
Hello, I'm Caroline. I'm a health and wellbeing coach mentor for London. So what that means is we're building up a network of health and wellbeing coaches, providing sources, bounce ideas around, trying to make sure that health and wellbeing coaches don't feel isolated, because I know they can feel like that sometimes when they first start, because it's such a new service, and trying to create some consistency and scaling up the service.
Thank you, Caroline. So we do have a presentation at the beginning of today's session, but we really want you to be contributing to the discussion, and want to keep it as interactive as possible. So, if there is anything that's coming up for you, any ideas, any thoughts that you'd like to share, then please feel free to put them in the chat. Liana, have we got the presentation up?
Are you doing your slides, Hina?
Yeah.
So if you bring up the slides, I've stopped sharing now. I can if you like, but I won't be able to see the chat.
Sure, I'll bring them up.
So just to revisit what we...
Go on. I was just saying, in the meantime, if you have anything that you'd like to particularly kind of discuss today, or bring up, or anything that's going really well for you, then feel free to put that in the...
Is it working?
Technology.
Don't worry. Just to revisit, for those that are just arriving, you'll have missed my preamble at the beginning. We're going to be looking today at the personalised care roles, why they're important for primary care, and how it relates to health inequalities. And we'll talk a little bit about the content of the roles, but we'll also be looking at some of the findings from the chats that we've been having with the system around what's working, and ultimately we're hoping this is going to be the start of a piece of work across London to think about how we can create a platform for really great examples of where this is happening and start a bit of a community of practice. I'm going to email Hina the slides. In fact, I think, yeah, okay. Really sorry. Hina, do you want to start talking to the personalised, why personalised care is important as I send you the slides?
Sure. I'll just start kind of talking a little bit about personalised care and why it's important to think about this in primary care. So firstly, what is it? So personalised care means people have choice and control over the way that their care is planned and delivered, and it's based on what matters to them and their individual strengths and needs. So it's person-centered care that strives to see an individual as a biopsychosocial whole and as a person, and not as a disease or a collection of conditions. And it is a big part of the NHS long-term plan to put in place more than 1,000 social prescribing link workers by the end of 2021, rising further by 23-24, with the aim that more than 900,000 people will be connected to wider community services that can help improve health and well-being. And so for London, this works at approximately 800 social prescribing link workers operating by 23-24, which is around 4 per PCN, with an average population size of 50,000. So I'm just going to bring up the slides now.
We've got quite a few of you in the room now. If you want to introduce yourself in the chat, I mean, part of the purpose of these meetings, and we do the same when we're meeting link workers, is for you guys to meet each other. You might be sharing comments and making, sharing some of your insights in the chat. Feel free to change your name to include your job description or what bit of London you're from, and introduce yourself on the chat. Great, they're showing now, Hina.
Great, so sorry about this, and finally we've got there, I hope. So we've kind of already spoken a little bit about this, introduced ourselves, and this is what I was talking about in terms of personalised care. So just thinking about London, 5 London boroughs are in the top 10 of the most deprived boroughs in the UK, and so personalised care, the personalised care role is an intrinsic tool for PCNs in ensuring community support. And it is important, however, to use these roles in teams that are, appropriate for local population needs, to think about how they can work together and how they're being embedded and to be used in the right way. We will be talking about this in more detail. But also we know that these roles can have significant impact on patients, communities and surgeries. Again, I'll go through some of the impact data that we have. So why are they important in terms of health inequality? So in London, we've made an active decision to look at embedding these roles with the focus of reducing health inequalities, because we know that over 80% of health outcomes are socially determined. That means that the conditions in which people live, work, grow, play are much more important in terms of the outcomes that they then go on to develop, much more than biology, genes, even healthcare access, although I would argue that healthcare access is also partly socially determined. So we really need to be thinking about shifting away from this medical model of healthcare provision that we have to really addressing the root causes. And this is where the social determinants come in. A note on using language as well. So we talk a lot about inequalities, but actually what we're talking about is inequities. So inequities are systematic, avoidable and unfair differences in mental or physical health between groups of people. And we know that these are widening in the UK and are highest in London. And disparities is another term that you might come across, which essentially just talks about differences within groups. And the Royal College of GPs has identified general practice as serving this key role in promoting vital community health functions, really looking after communities, and in particular with PCNs as being these anchor institutions where they can really address and optimize individual and population health outcomes, drive engagement between primary care and communities, and really promote cross-sector working. And just looking at some of the key areas of health inequalities, there's the core 20+5 approach that you may have come across, looking at 5 areas in maternity, serious mental illness, chronic respiratory disease, early cancer diagnosis, and hypertension case finding. But again, I really want to emphasize the importance of really addressing root causes and looking at the social determinants model. And you can see very clearly how PCNs fit into this model and traverse all these levels and promote cross-sector multi-agency working, joined up care and partnership working, can really promote co-production of services and resources with communities, reach out to underserved populations and empower them to have choice and control over their health. And it can they do simultaneously focus on individuals, communities and their environments, which not many organizations or institutions are able to do. Now, integrated care systems are going to be statutory from next year and are part of the long-term plan. And the aim is for them to fundamentally shift the way that health and care is organised and really to move away from this competitive and separation of commissioners and providers to focus more on collaboration and on places and local populations as the driving forces for improvement, and looking at improving population health and reducing inequalities, supporting productivity and sustainability of services, and enabling the NHS to support social and economic development, which is a really interesting but important area of work. Although it is going to be statutory, I need to emphasize that that local contextualized arrangements are going to be crucial in making sure that the ICSs function efficiently and effectively. So really focusing on local needs and resources and building local leadership. So now that we've got a little bit of background on health inequalities or inequities and how the social determinants are important in shaping health outcomes, I think it would be quite useful go through what roles are and then come back to how they can be used in developing or eliminating this health inequalities approach that we're taking in London. So over to Leanna and Caroline.
Thanks, Hina. I feel like so much of what Hina's been talking about is very leads quite nicely into why it's really important that we have social prescribing link workers. Social prescribing link workers, if we think about the integrated care systems and the need to have representation from lots of different stakeholders, that, you know, because we buy into the idea that lots of different bits are going to be pertinent to the health and well-being of the individuals that we're supporting through the health service. We need to have effective bridges into the community, and individuals working within the practices who are reaching out to some of the other stakeholders that are going to be providing services that are going to have a positive impact, hopefully, on patients' health and well-being. The social prescribing link workers who came in, who were introduced as a member of the practice, and I believe all PCNs are supposed to have at least one link worker working towards 4 for an average population of 50,000 come 23-24. That's their role. Their role is to build a bridge with the local community, understand what services are available, build relationships with some of those statutory services that are sometimes notoriously difficult to navigate, and take referrals of individuals who have social issues, the social determinants of health that Hina was talking about earlier, that are impacting or perhaps getting in the way of them being able to manage their health, and refer them, spend time with them, understanding what some of these wider issues are, and thinking through various activities or services that they can be referring that patient onto, and supporting that patient in engaging with, in order that they, you know, will have that with the assumption that this is going to have a positive impact on their health. So there's going to be spending time with individuals, getting to understand their wants and needs. They're going to be spending time developing the links with the community and the links with the services. They'll be spending time upskilling themselves on the particular needs of the types of groups that they might be supporting. Some link workers may be supporting people that are particularly lonely or frail, people who have complex mental health needs. We're seeing more and more referrals coming into social prescribing link workers of people that have got extremely complex needs, and it's really important that link workers, in feeling safe and confident to support those individuals, are getting the right kind of support themselves, to make sure that they are, you know, are well prepared for working with their caseload. More recently, we've seen sort of the growth of care coordinators in primary care, and we'll talk a little bit about how the 3 roles connect. But care coordinators have I guess it's best to talk about them in 3 ways. One is that they are a resource within the practice and the PCN, who work with people with chronic or long-term conditions, or who are perhaps particularly vulnerable, and help them navigate the system, and make sure that they're connecting with the right people. We know people with multiple health needs are maybe are going to lots of appointments, are having conversations with clinicians, and don't necessarily have somebody outside of the health system to discuss this stuff with. So allyship and continuity is definitely an important part of the care coordinator role. They're there to have follow-up calls with somebody and make sure that they support them in thinking about how they might be able to best engage with all of the appointments and navigate the system that they are having to engage with. We also know that clinicians' time is, you know, very limited, and care coordinators are a really important point of contact alongside clinicians. This brings me on to sort of it's really important that care coordinators are linked in with the clinical teams and are working closely with clinicians, because without this they become a basic admin role. And it's really important that, you know, we don't think of care coordinators as an admin role, that they are working alongside clinicians to support patients, to make sure that they can engage with the various bits of support that are coming up. They may see that someone has a social need, and they may refer them onto a social prescribing link worker who will have the expertise to connect them with the local, the relevant local services. They may identify that there's a behaviour change issue getting in the way of somebody engaging with their appointments. They may then refer on to a health and wellbeing coach, which brings me on to Caroline. Do you want to talk about health and wellbeing coaches?
Yes, I will do. Okay. So wellbeing coach is obviously one of the roles, a bit like
bit of an issue with your sound, Caroline.
Oh, can you hear me now?
Want to come a bit closer? Yeah.
Really close. Sorry, you've got a big so health and wellbeing coaches really help patients to reach a health goal. So in the first appointment, we would ask the patient what they want to achieve for their health. So for example, they might have been referred for weight loss, but actually weight loss might not be their primary goal. We might first work on some emotional issues or some mental health problems, which might be preventing them from losing weight first. So we really, it's completely patient-led. So we understand what the patient wants to achieve first and what's I guess achievable for them. And then we would try to understand actually what matters to them. So what are their intrinsic motivations for wanting to make a change? So for example, you might ask a patient, why do you want to lose weight, or why are you here? And they might say, well, the doctor told me to lose weight. But actually, that's an extrinsic factor, and that's not actually going to be much of a motivating factor to help them to want to lose weight. So we'd really get underneath the skin of why they wanted to lose weight, and what else is going on in their life. And really by doing that, we can help the patient to become empowered to take control of their own health. So we can increase their activation, help them to become more self-supported. And we can do all of this by helping them to make lifestyle and diet and exercise changes to improve their health.
I've just noticed Rafif's comment in the chat. Just for those of you that have joined, one of the things we outlined at the beginning, we're hoping this will be a regular meetup. So today we're looking at health inequalities and how the three roles, what the function of the three roles are and how they can be embedded within primary care and utilised in tackling health inequalities. There's been some discussion about, lots of people are really asking the same question as you, Rafif, about how care coordinators are working and wanting to hear how it's working in other places. So we're thinking that we will have a spotlight on care coordination in the session in January, but we can come on to kind of ongoing support towards the end of the session and revisit that. But just to say that there are plans to sort of go into some of this stuff in more detail and hear from what other people are doing across London. This is a slide that NHS England have pulled together, and it's an example of how the three roles can connect, and a simplification of what they're focusing on, what they're doing, how they can be used, and how the referral pathway might work. We're starting to hear as we're speaking to people in the system, there's actually lots of different ways it can work. If a care coordinator is doing a lot of the proactive case identification, it's possible that they are going to be making quite a lot of referrals to the social prescribing link worker and the health and wellbeing coach. A health and wellbeing coach may see that somebody has a social need that needs tending to. A social prescribing link worker may, or a care coordinator may identify behaviour change that might be needed, that is getting in the way of somebody being able to engage or make changes in their life. So actually, this is very much a work in progress, and I think it's going to be a piece of the work that Hina and I are doing to try and understand. It's not going to be working the same everywhere, and what we're hoping to do is get some case studies from yourselves and create a platform of examples of how it is working in practice. Obviously, there are a number of different referrals outside of the proactive case identification throughout a GP practice. GPs themselves, in some cases, primary care are taking community referrals. We know that receptionists and nurses who get to chat to people on a more regular basis or in a more in-depth way are a really good referral, can refer into these 3 roles, and also the pharmacists. There's going to be lots of other examples, but this is definitely something we want to be hearing some case studies of. So if there's any good examples out there of people that are doing it differently, we'd love to hear from you. So I'm going to hand back to Hina.
Thanks, Leanna and Caroline. So just thinking about some of the ways that 3 roles can be used when trying to tackle health inequalities, these are some of the things that we've seen PCNs do, also reported in literature. So we know that referrals to social prescribing link workers are associated with a range of positive health outcomes, reduce isolation, increase independence. And a study in Rotherham showed that actually an 80% improvement in long-term conditions and 90% for mental health users was reported. Care coordinators, I noticed that comment as well in the chat around the variation in how care coordinators are used, but I think that really points to the important message of really looking at what your local needs are and how you can use these roles to address your local needs and priorities. So some of the ways that care coordinators are being used across the system are, for example, looking at particularly excluded or vulnerable groups, so patients living in areas of high deprivation, ethnic minority groups, people with disabilities, LGBTQ communities, who have very high unmet needs, and actually positively looking for case finding and reaching out to these groups, coordinating care across sectors if they have multiple appointments or need assistance with linking in with a range of agencies. Sometimes your link workers may not be able to do that, but they would be working very closely with care coordinators, using the care coordinators to recall groups of patients where, for example, screening, care planning or annual reviews might be really low. That's certainly a way that we're thinking of using it in our practice. Health and wellbeing coaches, Caroline has already talked about, but preventing illness and activating motivation and achieving health goals can really reduce health inequalities by preventing illness develop in the first place and supporting and empowering self-supported management. What we also know, looking at the impact on the clinical workforce, is that 20% of GP time is spent on non-health matters, and actually this is much higher in deprived areas. And what this does is it leads to less time for GPs to really address patients' health issues. So by referring patients on to these other roles, not only does it release non-medical GP appointments, but it also makes sure that patients actually get the right support at the right place by the right person and at the right time. And by addressing the root causes of poor health, this will reduce demand for services. And there is a lot of data out there and the impact that it has on the system in terms of reducing hospital admissions, A&E attendance, non-elective inpatient episodes, GP consultations that I already mentioned, reliance on prescriptions, again, moving away from this medical model, and improved self-reported measures of health and well-being. And there are economic benefits as well in terms of social return on investment, and it does meet the NICE thresholds for cost effectiveness in studies on QALY. So what have we heard is working in the system, and if there's anything that we've missed here, and I've actually been looking in the chat, and there are some really good examples of people saying that we're having a lot of success with embedding these roles, and there are things that are working, and I'd be really interested in trying to understand what exactly it is that's working for you. So please do write anything that you'd like to share with your colleagues in the chat. But here are some of the things that we've heard. Giving these roles time to spend with patients. So, an example, so the suggestion for caseloads of 200, 250 per year does depend on the complexity for link workers. So it may be that, you have a population which has a lot of high complex needs. And so you may need to think about adjusting the caseloads for your link workers. And that's something that we certainly have in our patch, where we have a very, very high level of deprivation. So we need to be thinking about the caseload that our link work can actually take on. To build a meaningful bridge between primary care and the community, as Leanna's already mentioned, scoping appropriate activities. I know there were some comments about looking at community empowerment and the role of third sector organizations, and that's absolutely key, is really looking at how we can build those bridges between the health and social care sectors and also the community, and to really connect with each other, accessing peer support and ongoing training and development. And one of the aims of sessions like this is really to help you connect with each other, to learn from each other. We don't have all the answers here, and we're still learning from you as well, but it's really for you to really share best practice across the system. Embedding these roles within the PCN team, so attending MDT meetings, will enable a holistic approach to supporting patients with complex needs. And just a comment on this around MDT, they've become really fashionable in primary care. But again, we need to be thinking about who's coming to those MDTs. Traditional MDTs have, GPs, nurses, secondary care specialists. They might have a pharmacist and social worker, and a link, and personalised care roles attending as well. But if we're really thinking about joined up care and multi-sector working, then we need to be thinking about extending the, who we invite to these MDT meetings, and having people from other agencies, housing, employment, or, attending these MDTs to really understand what the needs are and support patients. Ensuring the three roles are working together effectively. There are a lot of interdependencies between the roles as well, and they'll only actually work well if they're talking to each other and working together. Ensuring there's a robust plan in place with an induction and a clear job role, and communicating to the wider referring workforce the purpose of the roles and how they can benefit the work of the wider practice. And again, if there's anything that we've missed here, then feel free to write in the chat. And here are some good examples of good practice that we've been hearing, but we'd love to hear what's working for you. And we'll be sharing these slides so you can read this later on. So I won't labor on the points here. And this is some of the support that's available in London to you. So the Healthy London Partnership Personalised Care Team, the NHSE associate roles. So myself, Leanna, Caroline, Ali Hassas, who's the care coordinator mentor, who unfortunately couldn't join us today, but he is looking at how care coordinators can be embedded across the system. We have local training hubs. I know we have people here from the local training hub, and the ICS personalised care leads for each ICS, with Dr. Jagan John, who's the Pan London lead. So this is some of the work that we've been doing. I've been doing with Liana and PCNs over the last few weeks that I've been in post. But we'd really love to hear about the type of support that you need that would work well for you. We're hoping that this will be part of monthly sessions, probably less structured in the way that it is today, but having spotlight sessions and themes that are emerging from what you're feeding back to us that you would like support with. And we're really looking for any volunteers of good practice or things that are working well for you, any creative, innovative projects that you're working on embedding the roles. We'd love to showcase that work. So please do reach out to us. We're also offering tailored sessions one-to-one with PCNs to explore the challenges, present any data that you feel you need to make those data-driven changes, because we know that is an area that PCN leaders have reported, and really forming links with you and the wider system. And we're hoping to co-produce a PCN toolkit and an FAQ guide. So again, if you would like to contribute to that, if you've got any examples of good practice, any case studies, any suggestions for what you think would be helpful to see in that toolkit and FAQ guide, then again, feel free to reach out to us or drop some suggestions in the chat. I can already see lots of really good things that are coming through. But over to you. We'd love to hear your ideas. And these are some of the resources that have been referenced in this presentation.
I think it would be good. There's some really interesting chat happening. Are there any questions? There's definitely a couple of things that have been mentioned around link workers working across PCNs. Any questions from the audience around these three roles? What sorts of things are you exploring at the moment? Feel free to take yourself off mute. Yeah.
Hi there. Hi, my name is Soa. I hope you can hear me.
Yeah, we can hear you.
Okay, so I'm one of the primary care delivery managers for North West London CCG based at Ealing. And I just, sorry, I didn't put my hand up. I haven't used Zoom before, so I didn't know where to do that. You normally use Teams. But I just wanted to find out generally what's some of the potential issues that could come up. I mean, I think with PCNs, the recruitment to some of these roles have been a bit kind of patchy or has been intermittent and not. I'm not quite sure if or most PCNs have recruited the numbers in those roles. So I'm just wondering what some of the challenges have been for PCNs, if you've come across any in recruiting to the roles and therefore embedding the roles. Sure.
I'm curious to hear from the audience. We've got some fantastic people in the audience. Is there anybody that would like to share or answer that question?
Hi, Leanna. Sorry, I haven't got a hand up function. I'm Russia. I haven't got one of those, so I'm sorry about that.
Don't worry.
I just wanted to respond really, because we had a bit of a problem at the original onset of SPLW. So I work in the Barnet PCN. I'm a GP there in one of the practices. Our PCN's got about, I think, 70,000 patients in it and 7 surgeries. I work with Rafif. She's also in our PCN. I used to be a long time ago recruitment consultant before I was a doctor. So the whole workforce sustainability and retention thing is something I'm quite passionate about. So when the SPLWs and the ARRS roles came in, the PCN asked me just to help lead on some of the social prescribers, and Rafif does care coordinators. And we had lost our first social prescriber who ever joined us. And I think it was because there was no sort of congruence between the practices and getting these patients, getting these social prescribers really embedded properly. Some of the things that I really found helpful was, first of all, having a standardized job description would have been really helpful at the start. So really clear, simple, 1-page, not 8-page JDs that allowed us to recruit actively. Our SPLW recruitment program was helped by Age UK and the third parties, and that was brilliant for us. But in terms of embedding them, I think the really important things that we found had helped was introducing them to the MDT early on. So inviting them to our actual PCN meetings that we have every week, making sure everybody could see their faces, that we could introduce them. Each one of our SPLWs is pretty amazing in their own way. They've got such great different skills. So knowing which one of them is strong in the mental health, which one's strong with older patients, which one's stronger with, and then we created I created a social prescriber WhatsApp group with the social prescribers on it and myself and some of the Age UK mentors, and we post useful links and updates to each other there. And the other thing is to just give them each, I think, a slot every week of a sort of 5-minute phone call. So I do it on a Wednesday and I give them 3 options every Wednesday morning. I say 10:15, 10:20, 10:30, and they can call me or I call them at that time. And we just have a general kind of debrief and any complex cases they can talk about. And they've really, I have to say, our retention's been good. We've kept the same 2, 3, only one of them had to go abroad, but we're re-recruiting. But we've managed to keep them for a significant period of, for more than a year, and they seem quite happy. But it was difficult at the beginning because actually there's no guidelines or pathways about how best to get them on board and how to keep them on board. So I think this forum is really helpful for that, people sharing. Yeah.
Great. I think that's really, really good to hear. And I think you've picked up on a couple of the things that that are answering the question. I think, I work with a lot of link workers across London. I also manage the Social Prescribing Managers network. And this is a conversation that comes up all time and again. How do we recruit good people? How do we retain good people? I think there's been a conversation about salary. I think the DES, whilst it says, it outlines what you can remunerate up to, I think where the lower bandings have been chosen and the individuals have been recruited with less experience, it's much trickier to retain those staff. They have less work, they're coming with less work experience. And actually there's a number of people across London that are recruiting to social prescribing roles. So paying people for and I know of a couple of services. Hackney's a really good example where the CCG top up the funding in order that all of the link workers there have a degree. There is Rasha's also talking about really refining the job description, and Geeta, I saw, had made a comment in the chat. This is about taking a step back, thinking about who we want this, how we want to use these roles, and really creating a tight job description and tight expectations around how this role is going to operate, not just with its patients, but also within the wider primary care network and the practices within that network. I think also, because you are looking to recruit somebody who has got experience of working with community organisations and community development, it's thinking about where to attract those individuals. So going out to voluntary sector organisations that are operating locally, the volunteer centres, individuals that are coming through that have got a really good understanding of the services locally, or perhaps paying to advertise on somewhere like Charity Job, where you're going to find somebody that's got a really kind of a breadth of experience prior to coming into a link worker. Any other comments? Kerry, you've got your hand up.
Oh, Leanna, can I just...
Yeah, I was
just for a second
about to say there's a lot of comments in the chat about the lack of career progression, and perhaps the desire for, I'm trying to put my hand down and struggling with that, while the desire may be to recruit people with experience and from from communities or from people that have got some sort of experience within an allied line of work. I mean, our experience is that we are seeing a lot of people with their first jobs from university that struggle with, they want to be everybody's friend, and that struggle with and take on more of a care coordinator role, which has also been highlighted in the chat, and with the lack of input from a PCN to actually manage the workload and the expectations of the role. It's you do have this fallout really of either people being burnt out or people just moving on, or actually going to the voluntary sector in a similar role where there's more opportunity to develop a career, and there's a lot more support. And so, I mean, Geeta, hello, and I totally agree with what you've said. We do need to actually take a step back, because it's a bit, like we want these roles to be the sort of, the golden gift in a way, to sort of take away all the problems of primary care, all the problems of that GPs and other clinicians are experiencing. When they can't, the clinicians get really cross and say, well, I'm not going to refer you. And it's, I think that step back is actually a reflection on what we want these people to do is just so important. Just so as we're not setting up everybody to fail and
Thanks,
putting
Kerry.
additional pressure on a collapsing system.
Thanks, Kerry. Hina.
Yeah, I mean, a lot of what we've been hearing around the job description, referral pathways is a common theme, and it is an area of work that we're prioritizing to support the roles being embedded, because this is something that comes up time and time again. So watch this space, and if you have any job descriptions or plans that you've done that have worked well, and Rasha, you're doing some really great work, then please do reach out, so we can share that with the wider system.
I think the other thing to say is, I guess as part of our work, we're connected with some of the things that are happening pan-London, and some of you will remember the rapid recruitment initiative last year. There's still an interest in thinking about how we can support PCNs to grow their teams. I mean, there are we had some chats with some really people that are taking a very kind of like forward-thinking approach, and have actually recruited a link worker per practice. And so for those of you that feel that you don't want to stretch your link worker across 5 or 6 or 7 practices, and think that there might be value in growing those teams, please do get in touch to tell us what you would find useful in terms of support to help grow those teams. Caroline.
I just wanted to, say I completely agree with what Rachel was talking about embedding these roles. It's really key to make sure that all of the ARRS roles are invited to all of the meetings and really, really promoting these roles and doing a kind of PR job internally, especially where these roles are working remotely. It's really easy for these roles to get forgotten about, or the clinicians not to understand who gets referred where, or who does what role, and it can be really confusing, and sometimes they can kind of be forgotten about or not be getting the right referrals. So I think all of that is really key. I just wanted to pick up on one thing that was happening in the chat box that Geeta was asking about supervision for health and wellbeing coaches, and the requirement for health and wellbeing coaches in terms of their supervision is that they need supervision from a qualified coaching supervisor that is accredited with the Personalised Care Institute. So normally there's 4 providers of the training for health and wellbeing coaches, and those 4 providers also can provide supervision. So unfortunately that supervision requirement needs to be kind of outsourced externally, especially in the short term while we don't have any qualified coaching supervisors, I guess, within our pool at the moment. So it kind of needs to be tagged on to the training where you're getting the training for health and wellbeing coaches. You can also, I guess, purchase the supervision at the same time. Does that answer your question, Geeta?
Hi, yeah, no, that's great. Okay, I'll ponder that a little bit further, because I'm.
Can I ask?
There is I mean, I think it's a big challenge here, because everyone looks to the contracts, and then new roles, new to primary care, you wouldn't start here, and then building on the experience for social prescribing link workers, I suspect what was the learning from that around supervision, and what is that then, how is that being the learning being taken forward into the needs of health and wellbeing coaches and care coordinators, who are even more isolated sometimes. They're not necessarily part of a team. And I think the PCI stuff, I mean, I get why we're being directed to it, but that is also quite a challenge, one, to navigate and get around the system, and the provision around health and wellbeing coach training, the 4 providers around accredited training. I wasn't aware that they would also be the providers for supervisors. But I guess what I'm actually saying, and I don't expect it to be answered here, but what I'm trying to visualize is, who is the embodiment of a supervisor for a coach? And I think that is really hazy, and that is pretty unclear. Is that somebody like a GP who's super interested in that agenda, or is it another type of clinician, or could it be, I know, a PCN manager, right? It's kind of, I think it's, the jury's out about clarity about what that actual person might look like. And like I said, this is all in its infancy, and we're all trying to kind of, make some assessment of the kind of support needs and how do we manage that in a coherent way. But I do think it's an issue, is I guess why I'm flagging, London to use some of the levers at a strategic level, because it's not going away, and it's writ large across all of the personalised care roles, whichever one of the 3 one might be talking about. I mean, everyone's tried to find solutions, to collective solutions for link workers, because they came in a critical mass, but that hasn't even been resolved without before we even think about the needs of the other 2. I'm not being a naysayer. I just think, I mean, I'm a big advocate, as a lot of people know here, of a champion of the work and these roles, but I am concerned about retention and turnover when people don't feel supported, and that is an absolute critical element of however one chooses to define embedding, which seems to be a theme. Anyway, could talk more, but yeah, thanks very much.
Caroline, can I just ask, just following on Geeta's question, you said about the external supervision. So my question is, who's going to pay for the external supervision? Because I've taken a year to try and sort out, which we've got Zero on this call as well from our Waltham Forest Training Hub, who has really worked closely with us in social prescribing. providing the non-clinical supervision and paying for it, but who would pay for the health and wellbeing coach supervisor, you know, the external supervisor, as you said, given that the ARRS money is supposed to be strictly for salaries?
Yeah, and I guess that's the challenge, really, isn't it? I guess potentially the same place that the funding comes from for the training. I mean, this is the challenge, because long term we don't want to have the conversation every year to find funding for these things. So I'm not sure I have the answer to that, I'm afraid.
Can I just come in? Billen, who's the personalised care lead, senior programme managers, has said, made a comment about the funding, that it's for health and wellbeing coach supervision, and it's currently being looked at in ICSs. So it might be worth contacting your ICS clinical lead to see how that's being looked at within your locality.
There's quite a lot of chat about the funding in so there's a Tessa, could you clarify what you believe your comment about the funding coming under the PCN development fund pot?
Yeah, sorry, I'm just trying to find the link and I haven't been able to find it. I was in a discussion with Croydon Education Group, and they was asking a very similar question. And sorry, I represent, I'm here representing a PCN, but I also work for Wandsworth Training Hub. And as far as the Training Hub is concerned, we understand that there is a PCN development fund, and some of that money, I'm trying to find the link to the actual document, some of that money can be used for supervision purposes. I'll continue to try and find the link, and if I can't find it before the meeting ends, I will certainly email it to you, so you can kind of look into it a bit further.
Sarah's commenting that she's not sure all PCN development pots can be used for supervision. I think this is
Liana, I can probably answer that one. It's on page 26 if anyone wants to see it, on the SDF funding, because I've gone through it 100 million times.
Oh, thanks,
and it's on page 26 of the SDF funding that's released by NHS England. There's one line, it says PCN development pot can be used for, but as a training hub lead in 2 parts of London, I can more or less assure you that most PCNs will not be looking at that pot of money for the supervision bit, because they're expecting other parts of the system to pick some of that up. And since Caroline told me about the PCI accredited bit with the health and wellbeing coach supervision, I think it's complexity until at ground level, PCN CDs expect us to take complex information, simplify it and give it to them. And if we're not able to do that, we're not able to support the recruitment, the retention, all the other bits around it. So definitely on page 26 if anyone wants to see it, but I can't see the PCNs putting it as part of their development plans, plus the CCG handholds that a lot.
I feel like some really useful stuff is coming up. We're at the end of the hour. My sense is, Hina put up a slide with regards to some of the stuff that we're going to be working on. Essentially, it feels like it would be useful to get together once a month to have some people sharing examples around some of the challenges we are hearing. And the things that have come up today is how to best use the funding, what funding's available, and how to best use that funding. How are people measuring impact of these roles? How do you actually use a care coordinator? It'd be useful to go into that in a bit more detail. Utilising these roles across the PCN, just rather than just the surgeries that perhaps are taking the lead on recruiting these roles, and then supervision and support. I'm sure there's lots of other challenges, but it's picking up some of these themes and then getting some examples from the system, people to present and have a bit of a chat afterwards. There's some really useful people in the room here who've got lots of experience and knowledge from in a lot of different aspects of these roles. Is it safe to say, we'll be in touch with a follow-up after this meeting? Is there anything else you want to add?
Yeah, absolutely. We will be in touch, and the chat has been really, really interesting, helpful. We will be going through it and looking at you know, some of the issues that have been raised, and looking at how, you know, we can reach out to you or hold more of these sessions, specifically looking at the challenges around the ones that have been raised today. And if there's anything that you feel would be particularly helpful to you to run as a learn and share session, then again, let us know. We're here really to kind of build links between you so that you can support each other, and we're merely kind of facilitators. But you know, do feel free to reach out about anything that has come up for you today, things that we weren't able to go into detail about because there was so much covered. And you know, myself and Leanna are available to answer any questions. Caroline is the health and wellbeing coach, mentor. So if you have any specific issues around the development of that particular role, then I'm sure she'll be happy for you to reach out to her as well.
Sorry, I just got kicked out of Zoom. I will be sharing the slides with everybody after this session. We'll go through the chat and pick out some of the examples that you guys have shared as well. Thanks, everybody.
Thank you.
Thanks, everyone.
Hina, I think I've made you are you still co-host?